And he will also share with us some of the insights on the Harvard experience. Samira will then follow with an appraisal of the principles of management of high-grade B-cell lymphoma with the available literature. So may I hand over to Samira so we can get it. Thanks.
Thanks so much, Dr. Bassa, and also just to add my own personal note of thanks to you for helping me put this presentation together and deciphering what actually turned out to be quite a complex topic. So thank you so much for all the help that you provided in getting to the point where we are to present this. Right. So as Dr. Bassa has said, high-grade B-cell lymphoma is now its own unique entity. She also mentioned that it traditionally has been used to describe B-cell lymphomas that just morphologically had high-grade features such as numerous mitotic bodies, or if they had a high proliferative index with the key. And consequently, before 2016, neoplasms such as lymphoblastic lymphoma, Burkitt's, and certain variants of diffuse large B were all encompassed within this term. But as of 2016, that changed. High-grade B-cell lymphoma defines its own distinct entity, which is recognized for its unique biology and clinical characteristics and often worse outcomes. If you can see in the little diagram, it shows a change where these were classically these gray zone intermediate between diffuse large B and Burkitt's. And most of these have been reclassified either as high-grade NOS or high-grade B-cell lymphoma with the relevant translocations. So this term now, well, as I've just said, encompasses high-grade B-cell lymphoma with MYC and a BCL2 and or BCL6 rearrangements, or colloquially we call them double hit or triple hit lymphomas, or high-grade lymphomas not otherwise specified. Now, I'm going to make a bit of a relevant digression, which is where we were to explain where we've come. And this is particularly relevant with the lymphoma that, although it's been renamed, is actually still a bit of a gray zone lymphoma. So the 1950s is when the very famed Rappaport classification came out. It had 5 categories and had 2 growth patterns. There was a complete reliance on morphology, but oddly enough, a lot of this still remains in how we recognize classifications today. They oddly enough, and it's kind of with a bit of irony that you can see it wasn't immediately accepted because they thought this was too detailed. Looking at classifications now, it's almost laughable that this was considered such a complex way of classifying things. But still, it provided the basis of what was later used in clinical studies. The 1950s then brought several new classifications, but they weren't truly built upon the preceding classifications. What they essentially did was toss out the prior classification. And the author, I think, a little tongue-in-cheek notes that he thinks they partly threw away the old classifications because they were named for the previous author, highlighting one of the many issues with eponymous classifications. The other issues in the 1950s was that there wasn't a sufficient understanding of the immune system. Lymphoid cells were variably referred to as reticular cells or histiocytes. That somewhat changed in the 1960s. There was a recognition of the origin of B cells and T cells, and that lymphomas were actually neoplasms that were of the immune system. This cell of origin is what they thought now should be the basis of classification. The Lucent, Collins, and Keel classification were the next big ones, the big names in the development of lymphoma classification systems. And here they decided to name them based, as I mentioned, most close to the cell that they most closely resembled, so the cell of origin. They also acknowledged that you couldn't just use morphology, that there needed to be a multi-parameter approach that integrated morphology. In the 1980s and 1990s, the NCI working formulation, which they actually criticized as being a bit of a step back because it went back to morphology alone. But then the real classification came out, which actually was the first one that truly built on previous classifications and other published studies, where it wasn't so much about new information, but compiling what was existing information. They divided cells for the first time into B, T, and NK origin cells. And again, they emphasized that multiple parameters were needed in order to make this diagnosis. If you notice this article, and what I'm quoting is actually the main author of the WHO classification. So if anybody has some time, they really should read it. It's a very interesting read from somebody who has the retrospectoscope to look at how these things evolved. In any case, the WHO classification was first published in 2001, but actually arose from a meeting in 1997. So at this point, they'd learned from their past mistakes of different people putting different classifications out. They established an expert committee of 44 hematologists and oncologists, and they decided on a mutually agreeable classification. It emphasized clinical pathological correlations, and it's divided into sections that we broadly know now, B, T, and NK cells, with Hodgkin's lymphoma still being segregated, even though we know that in the vast majority of cases, it arises in B cells, but even today, it remains as its own entity. And the point of this, and what Dr. Swerdlow tries to emphasize, is this was to create a framework, a structure and function that allowed for the evolution that was clearly coming in lymphoma. So in 2008, they published the next blue book. However, the field was so rapidly developing at that point that in order to maintain relevance, they needed an update. But the 2008 classification hadn't actually been published yet. And that's how we got the fourth revised WHO book in 2016, which was essentially a fifth edition. But because it was developed before the third edition, they couldn't call it that. And that classification continued to increase. And actually, if you look at the number of lymphoma entries, it's almost triple the number from 2001 to 2016 in a matter of 15 years. So one of the main changes in what I'll be discussing here is high-grade B-cell lymphomas with the translocations and high-grade B-cell lymphoma not otherwise specified. But since this classification, since these classifications, there's been these new definitions that have now been established. Well, I think they were always in use beforehand, but they were formally established with the new entity of high-grade B-cell lymphoma. So just to define it for everybody, double hit lymphoma, mature B-cell lymphomas, they have a MYC rearrangement and BCL2 or 6 rearrangements. They can arise de novo, or they can arise on the basis of other lymphomas like follicular lymphoma, and they have a spectrum of morphology. Triple hit lymphoma is largely the same, except it has both the BCL2 and 6 translocations in addition to the MYC rearrangement. High-grade B-cell lymphoma, not otherwise specified, is a morphological diagnosis primarily, and has features that are intermediate between DLBCL and Burkitt's lymphoma, but they don't have the required oncogenic hits, though they may have other aberrations. And then double expressive lymphomas, which I'm not going to deal with here, but that's based on the expression of MYC and BCL2, over 40% for MYC and over 50% for BCL2. So they widely acknowledge, as you can see in the graph here, that the yellow line, patients with double expressive lymphomas do far poorly than other patients with diffuse large B-cell lymphoma. And then, of course, patients with double hit fare the worst. So since these new definitions and since the new classification, again from Stephen Swerdlow's article, he then reflected back on the philosophy of the WHO and how strictly we apply these terms. So he looked back and said that the WHO book's more reflects an evolving consensus with no absolutes, and it really shouldn't be treated as gospel. It also oversimplifies reality, and it doesn't provide for the gray zones that we often encounter in daily practice when we deal with these lymphomas, and specifically with high-grade B-cell lymphoma, which in itself is still largely a gray zone of diagnostic difficulty. So just to give some information on the characteristics of double hit lymphoma, I do have a bit of a caveat. So the articles here, the article I'm quoting here is actually written by a pathologist. So the stats regarding the patient's yeah, it's not based on a systematic review of the evidence. The data, how it was compared, was also not made clear in the text. And some of the studies were also relatively old. So please take that but it still very nicely puts everything together. So I thought it would be worthwhile to include, because finding review articles on this topic is incredibly difficult. So with that in mind, the article says that 75% of cases have a co-arrangement with BCL2. So as I mentioned, they must have c-Myc, but the partner most commonly is BCL2. Regardless of whether it's BCL2 or 6, demographic and clinical data appear similar. It tends to be a disease of older, or rather lymphoma of older patients, 60-year-old with a male preponderance. Patients often have advanced stage disease and extranodal disease at presentation. The overall survival, I'll talk a little bit more towards this when we're getting to management, but they estimate overall 8 to 19 months is the median survival. Triple hit lymphoma is not recognized as a distinct entity from double hit. 15 to 20% of cases will have this though. Again, based on this article, they say there's clinical and demographic data that is similar, but there are far fewer studies that look at triple hit on its own. Just to highlight here, it seems to be an older age group, majority of them men with advanced disease, poorer ECOG, and a higher incidence than one would expect at presentation of CNS involvement, high LDHs, and high IPI scores. Just because I wasn't entirely happy with how that data was derived, one of the larger retrospective studies, which I'm going to chat to when we get to management, they did summarize some of their epidemiology, which is actually similar in fairness. So this was a retrospective study published in 2020. It looked at 160 patients from 2013 to 2019. Looking at double hits with either BCL2 or 6 rearrangements, as well as a small proportion of triple hit lymphomas. They did show a similar age, so 62 years is the median age with the male predominance, again emphasizing advanced stage disease in 90% of them, elevated LDH, high IPI scores, and 14 of the 130 patients who were actually tested at baseline did have CNS involvement. They also noted that progression-free survival and overall survival was similar across the different, regardless of which the second hit was, so i.e. BCL2 or 6, that it was associated with MYC. But I'll talk about the outcomes a little bit later when I refer back to the study. So high-grade B-cell, not otherwise specified, is an even more difficult category to define. This is a very good review article that was published in Blood this year, which does speak well to how difficult it is to comment on this. So it's even more rare than double hit and triple hit lymphomas. It was previously a large portion of them with the B-cell lymphoma unclassifiable category, and it is defined entirely by morphological parameters, which of course leads to inconsistent diagnostic patterns. There's no unifying immunophenotypic or cytogenetic findings, though a significant proportion, 45%, do carry a single c-Myc rearrangement. A slightly older epidemiology of 70 years old, male-female equal distribution, and no reliable prognostic data. So they suggest that at presentation they have a lower IPI and possibly that they may have a better prognosis, but with a lot of more of an expert opinion than based on hard research. So high-grade NOS is divided into 2 morphological variants. The first one is B-cell lymphoma unclassifiable. So these are general center B cells with the immunophenotype reflecting that, i.e. CD10 and BCL6. They have Burkitt-like morphology, but they're more pleomorphic and sometimes have lower key staining. Otherwise, they can be indistinguishable from Burkitt's, except they have expression of BCL2 and LAC-CD10, which are quite pathognomonic findings in a Burkitt's case. Cytogenetics and other characteristics are not typical of Burkitt's, though it's important to exclude Burkitt's light lymphoma, another newly defined 2016 classification, which is Burkitt's lymphoma with 11q aberration. So 5 to 10% of them can also lack the classic c-Myc rearrangement. So it's important not to call this category if you have a Burkitt's lymphoma that otherwise exactly looks like Burkitt's lymphoma, but doesn't have what we would classically expect, the 814 translocation. The second variant is the blastoid variant, which is even more rare. These are intermediate sized cells. They have blastoid morphology with a mature phenotype, i.e. they're TDT negative, and they have a more mature B cell marker, CD20. But it is important to then exclude B lymphoblastic lymphoma and a blastoid variant of mantle cell lymphoma. So I'm not going to go too much into the diagnosis. The guest speaker will speak much more to this, but basically high-grade NOS, it can look Burkitt-like, blastoid, or diffuse large B, and that's basically how you would define it into either the DLBCLs, which become DLBCL NOS, or if they have the FISH characteristics triple hit. But if they just on morphological grounds meet Burkitt-like or blastoid, they become high-grade B NOS. And this is the famous diagnostic algorithm. Again, I'm not going to go too much into it, but how one would then differentiate morphologically, immunohistochemistry, and FISH-wise, which lymphoma one is dealing with. So there has been evolution since the 2016. So there are still pitfalls in the current classification. And again, the same review by Dr. Swerdlow, just to circle back from that digression I made, he actually speaks about high-grade B-cell lymphomas and how it's a much more complex diagnosis to make than one would initially see with just an algorithm. So despite this recognition of how complex this disease is, there aren't actually new agreed approaches to define which cases should fit into this category. So there have been methods where they wanted to identify extra aggressive large B-cell lymphoma. There have been criticisms that double and triple hit DLBCL is insufficiently precise. And by that, they really mean that multiple genetic bases for BCL2 and MEK dysregulation exist. So how does one decide which ones are included and which isn't? For example, an individual may have a chromosomal rearrangement of one gene and a copy number increase or amplification of another gene. And even the WHO mentions that cases with a c-Myc amplification and a concurrent rearrangement probably will do as badly as a classic double hit lymphoma, but that's not enough to classify it this way. And then even just looking at rearrangements, which rearrangements matter? So we talk about a c-Myc BCL2 and BCL6 rearrangement, but a very important study showed that c-Myc rearrangements which were translocated to an IG partner versus a non-IG partner, those that were translocated to the IG partner did inferiorly to the non-IG partner. So even the partner matters. And then the double hit signature. So just like we have Burkitt-like and Philadelphia ALL-like lymphomas, there are also double hit signature lymphomas, which are being recognized when they've done studies on RNA sequencing. So this category of a molecular high-grade B-cell lymphoma becomes far harder to define. And whether we'll ever have the tools for that, or whether getting to that point will rely on gene expression profiling, is something that we need to look towards the future, and also look at the new WHO classification, which I'm sure many of us are eagerly awaiting. So looking at high-grade B-cell lymphoma in South Africa, there's quite a paucity of data. We don't really know the prevalence in an HIV endemic setting, what the testing patterns across the country are, and what the management practices are between different centers. FISH is also the only modality we currently have in state to identify cases. In Tygerberg, at least, all our diffuse large B cases and cases with any intermediate morphology go on for further testing for c-Myc. So we have a standardized algorithm, and hopefully that's the best we have. Well, it is the best we have at the moment to identify high-grade cases. My understanding of the private settings, they largely are using FISH testing. I think I've heard that Pretoria East is looking at setting up an NGS lymphoid panel, but I welcome any corrections there if people are doing any further testing. So I'm looking at high-grade B-cell lymphoma from 2016 when the new classification was, had arrived till 2021, specifically because we have an HIV setting. There's been a lot more challenges than I anticipated. At the moment, we still are having debates about which cases are truly high-grade B-cell lymphoma. And I hope at least in some part I've explained why it can be so difficult to just rely on what the WHO says versus what actually is seen in the real-world setting. So aside from the diagnostic difficulties with FISH, we often have failed testing, and that largely possibly relates to sample adequacy. Often we only get core biopsies, so excision biopsies are a rarity, unfortunately, for us. And that does compromise the quality, especially if we're diagnosing it on things other than the lymph node. A couple of patients with liver masses or renal biopsies makes it far harder. Additionally, although we have the algorithm, it's not uniformly done. And some cases which have a MYC positive test don't have additional testing. So differentiating diffuse large B from high-grade B-cell lymphoma has been proven incredibly difficult. We also don't have a library of confirmed case. So basically this was going through divisional databases or our divisional database to look at new cases. But there's also a learning opportunity here. It definitely is a debate with the pathologists, and it is interesting to see the difficulties on their side as well as on our side. But this discussion has led to us looking to create a new lymphoma database, ongoing discussions with both departments to try and fine-tune testing so that we really can better define this really difficult to define group. And of course, I think the number one or the first goal would be collaborative research with other departments in the Western Cape, or if not that, South Africa would be great as well. So this is very preliminary. As I said, we're still debating which cases even fit into this, but there were 35 cases of high-grade B-cell lymphoma that I've currently had. 23 of those 35 patients, which is roughly 66% of the patients, were HIV positive. So this is the data just on them. Much younger age than what we've described. So our patients were around 34 with a range of 31 to 53, male, female, equal distribution. And the HIV at baseline, you can see a majority of our patients had CD4 counts under 200, 47% of them had viral loads that were over 100. And actually only 30% of our patients had been on ARVs for longer than 6 months. They presented, as the literature does suggest, with more aggressive stage 3-4 disease, extranodal involvement in the vast majority. 29% or 7 of the patients had CNS involvement at diagnosis, and 13 had bone marrow involvement. Of the histology, as I said, this has still been an issue of debate, but high-grade B-cell lymphoma not otherwise specified made up 21 or 91% of the cases, and our double-hit, triple-hit FISH were 2 cases. And that's all for me for now. And I'm going to hand it over to the guest speaker to discuss more on the diagnosis of these lymphomas. Thank you.
Thanks, Samira. I notice there's no questions in the chat box, so perhaps Mark can get going. Thanks, Mark.
Certainly, thank you. Thank you, Fatima, for the invitation. I also wanted to thank Dr. Antel for connecting me with this group. It's really a pleasure to speak to a new crowd that I haven't met before. And I wanted to thank Samira for that wonderful perspective in your talk. So I'm going to share my screen and let me know if you're seeing my title slide.
Yes, we can see it. Thanks very much.
Okay, great. Wonderful. So I'm going to, just by way of introduction, I wanted to say that my focus, as mentioned in the introduction, is primarily on molecular diagnostics in lymphoma and leukemia and molecular biology. And so you'll see that bias come through in my presentation. What I'd like to do in terms of an outline is begin with an overview of the evolution of our approach to molecular classification in lymphoma, with a focus on gene expression-based biological programs. And then I will review the current Harvard experience in terms of our diagnosis and treatment of these aggressive B-cell lymphomas, and then spend several minutes at the end providing some of my perspectives on where I think we have an opportunity to move the field forward, but also some of the key challenges that we face in doing so. And I think one thing that you'll soon realize is that I think we share many of the same challenges, and so I think all of us have aspirations for the field to move forward more quickly into the era of precision medicine. I think in many ways remains an aspiration more than a reality. So without further ado, I'll get started. So I will just go back to the beginning and just review a few seminal events in the field. Many of you are familiar with this report from 2000 when Ashley and colleagues used a gene expression-based platform to evaluate diffuse large B-cell lymphomas and identified this subgroup with transcriptional similarity to in vitro activated B cells. And this group was associated with higher clinical risk following standard therapy. Now, it's important to note, and I'm showing just representative data on the left, that this kind of gene expression data is both, presented technical challenges, interpretation challenges, and application challenges. This was based on these lymphochip competitive microarrays, which subsequently could be replicated with these Affymetric microarrays. And the key is that these required fresh frozen tissue to measure the expression of thousands of genes. And for a number of reasons, this was easier to execute in a research setting than in a clinical setting, where most of the tissue, we also primarily are receiving archival tissue when we're kind of making the diagnosis and doing our second opinion consultations. And so this was, clearly a seminal work in that it both identified two coherent biologically defined subsets of diffuse large B-cell lymphoma in the germinal center similar lymphomas, and then the activated B-cell similar lymphomas. And these did have clinical correlates in terms of clinical outcomes, but they were not very easy to translate, leading to a series of attempts to replicate the identification to resolve these biological subgroups with more tractable methods, primarily based on protein expression in the form of immunohistochemistry. And a number of those approaches are shown here. This came from another really nice review that was published 3 years ago. This is showing the protein expression that is the basis for these classification systems and when these were first reported. And the field has been, I think, globally has been relying on the Hans algorithm for many years now, based on its simplicity and its tractability and the reasonable robustness of this approach. Now, of course, there's the precision of this approach was limited, and there was a longstanding interest in defining these two subtypes with greater granularity, yet with some degree of clinical tractability. And so the nanostring-based platform, which has been around, I think, since I was a trainee back in the 2000s, what offered the opportunity to identify the expression of limited numbers of genes from archival tissue, did not require fresh frozen tissue. And so the group in Vancouver developed a 20-gene nanostring assay that was able to resolve these two subgroups of lymphomas in comparison with the gold standard, which was evaluating fresh frozen tissues by microarray. And they revealed a concordance in 67 out of 68 evaluated cases between the nanostring assay and the microarray-based gene expression profiling. Moreover, they specifically tested for interlaboratory concordance. And so there were two separate labs that evaluated all these specimens, and they found that there was a significant degree of interlaboratory concordance. This is important because one of the shortfalls of a number of the immunohistochemistry-based approaches is that it's, to the extent that it relies on pathologist interpretation, it has liabilities for inter-observer variability and inter-laboratory variability. In any case, this nanostring-based assay called Lymph2CX was successful in resolving clinically divergent subgroups of DLBCL in a manner that mirrored what was seen with the microarray-based testing. I will mention that this Lymph2CX assay was actually in the United States, the process for obtaining approval to use a diagnostic test to guide clinical decisions is called CLIA certification. And Lymph2CX was CLIA certified and it was actually available through the Mayo Clinic for some time. Although interestingly, it was not widely used outside of the Mayo Clinic, and it actually wasn't used by our group at Dana-Farber. And I'm not actually. It appears to me that it's not currently offered at this point. But this was an important development in the field in terms of gene expression based diagnostics for DLBCL. So this is from that same review, a nice overview of the current methods for cell of origin determination in DLBCL, which again, I'm mainly providing as more of a precursor to the molecular resolution of these high grade subtypes. But just showing, this is a nice summary because it shows some of the key features in terms of that I would say, which would be tractability in archival tissue, interlaboratory reproducibility, and expense. And what I'm showing here is, this Affymetrix array would be what would be most similar to the original reports by Dr. Elizadeh. And then the nanostring-based assays were those that were subsequently, or the immunohistochemistry assays, of course, the series of them were reported suffering from poor precision, but being very tractable in archival tissue and relatively inexpensive. And then the nanostring, the digital gene expression array-based testing platforms offered compatibility with archival tissue, greater interlab reproducibility, and reasonable expense. And what the field, I think, will be moving towards in the future are more of these, what we can typically think of as like RNA sequencing based assays, largely based on Illumina chemistry, but these are quite immature and there have yet to be, I would say, extensive and robust reports of these kinds of approaches. So in terms of cytogenetic biomarkers of clinical risk, this was nicely reviewed by Samira, so I won't belabor it, but there were a number of studies during the early, in 2009, 2010, revealing this adverse prognostic impact of these key gene rearrangements in MYC, BCL2, and to a lesser degree in BCL6. And these were specifically in terms of outcomes after standard R-CHOP therapy. And as a result, these were incorporated into the WHO classification in 2016. And these kind of motivated efforts to further define the biology of these subtypes through these gene expression-based platforms. And so in pursuit of greater resolution in terms of the diagnosis and defining biologically coherent subgroups, there were two high-profile groups that concurrently reported, I would say, partially overlapping molecular signatures defining these groups of high-grade B-cell lymphomas in 2019. And so the first that I wanted to report was the group from Vancouver, the British Columbia Cancer Agency, first author of Dr. Anishi, and they were seeking to define gene expression signatures that distinguish these high-grade B-cell lymphomas with double or triple hit biology, but mainly with BCL2 rearrangements from other germinal center derived DLBCLs. And so they evaluated 157 de novo germinal center B-cell lymphomas, DLBCLs, 25 of whom had a double hit or triple hit biology. And they evaluated these tumors with RNA sequencing, whole exome sequencing, targeted gene resequencing, as well as immunohistochemistry. And they identified a set of genes that were the most differentially expressed between the high-grade double or triple hit involving BCL2 group and other germinal center B-cell DLBCLs. And they used these to nucleate a 104 gene signature. And then they compared the results of evaluating lymphomas that expressed this signature the most strongly, what became this double hit signature, with the results of other orthogonal approaches in terms of immunohistochemistry, FISH for MYC and MYC BCL2 and BCL6 rearrangements, and immunohistochemistry-based protein expression. And what they're showing here, which was quite remarkable, was the fact that this double hit signature, gene expression-based signature, captures a number of DLBCLs that lack many of the other conventional or lack double hit features by conventional approaches. And this group was biologically coherent as well as clinically coherent in that it did define a poor risk subset of germinal center B-cell lymphomas with outcomes following R-CHOP therapy that were more akin to those seen with ABC type DLBCL. And this was by multiple survival endpoints. This was validated in an external cohort as well. And so in summary, the Vancouver group defined this 104 gene signature, which they called the double hit signature, and it characterized 27% of germinal center DLBCLs. And interestingly, only half of those were known to be double or triple hit by orthogonal means, and suggesting that there are other biologically convergent features that generate similar biology, and motivating the pursuit of additional molecular tests to capture these entities. The double hit signature positive patients had inferior outcomes, and what's probably beyond the scope of today's talk is that these tumors manifested biology that was most similar to the dark or intermediate zones of the germinal centers, and they had mutations in chromatin modifier genes that were reminiscent of those seen in follicular lymphoma, and in the context of recent molecular classification approaches, suggested the possibility that these could be related to transformed follicular lymphoma, or at least a subset of them could be. Of note, the nanostring assay called DLBCL90 recapitulates the double hit signature, and this has been deployed in a research capacity in a number of institutions, but to my knowledge has not yet been deployed clinically as a CLIA assay for clinical use. So in parallel, another group looked at, I took a similar RNA-based approach to define a poor prognosis subset, and the goal of this group was not quite the same as the Vancouver group. They were, I would say, they were taking a more de novo approach to define a subgroup of large B-cell lymphomas with poor prognosis and phenotypic similarity to Burkitt lymphoma. They evaluated retrospectively 928 patients with DLBCL from the Remodel B trial, which you'll remember is the attempt to improve upon standard R-CHOP therapy through the addition of bortezomib, based on the hypothesis that that inhibition of NF-kappa B signaling would lead to improved outcomes, at least in subsets of DLBCLs that were dependent upon NF-kappa B signaling. And they used the gene expression, they reanalyzed existing gene expression data and supplemented this with targeted DNA sequencing using a 70 gene panel. And this is a very dense, complicated figure, but suffice it to say that in addition to classifying the DLBCLs from the Remodel B trial, they also included a subset of Burkitt lymphomas, given the fact that there was existing understanding that there was biological similarity between the high-grade B-cell lymphomas and Burkitt lymphomas, and so they included a subset of Burkitt here for the purpose of classification, and they evaluated these, they clustered these lymphomas according to gene expression patterns as well as mutations, and resolved a subset, a distinct subset of these molecular high-grade lymphomas here, which appear to be intermediate between germinal center B-cell DLBCL and Burkitt lymphoma, and expressed a number of kind of pathogenic transcriptional pathways that one might expect. Now, in terms of where these molecular high-grade cases segregated, they primarily, they existed mostly in the germinal center B-cell DLBCL subgroup. There were a small number that would have otherwise been classified as ABC type DLBCLs, and a smaller number that would have been unclassified. And these were this was associated with with inferior survival outcomes following RCHOP. There are several Kaplan-Meier curves shown here, but the upshot is that the molecular high-grade group had an inferior prognosis with RCHOP, and since we're talking about remodel B, it's notable that it was that adverse prognostic impact was not fully attenuated through the addition of bortezomib. And this molecular high-grade group was enriched for a number of other high-risk features, other clinical and biological high-risk features. What I thought was very interesting is that this group also evaluated a number of recurrently altered genes in DLBCL and associated this with the molecular high-grade transcriptional signatures. And again, this is very detailed to go through, but I'm just summarizing here some of the genes that were most commonly mutated in these different groups according to their reanalysis. And the mutational pattern was, I would say, intermediate between germinal center B-cell. There were features in the high-grade B-cell lymphoma group of both germinal center B-cell DLBCL as well as Burkitt lymphoma, but a little bit more mutational similarity to Burkitt, notably in terms of MYC alterations, DDX3X alterations, but in terms of similarity with Burkitt lymphoma, but a number of the epigenetic modifier genes that were altered, similar to germinal center B-cell DLBCL. The molecular high-grade group encompassed most of the patients that were double hit by immunohistochemistry, as shown here in panel A. And interestingly, this group had a poor prognosis, but it was of interest that if you remove the molecular high-grade from GCB DLBCL, the group that remained actually had a favorable prognosis, which was, I think, another intriguing aspect of this signature and its ability to inform prognosis and, in the future, potentially therapy. So in terms of summary, this transcriptional molecular high-grade group consists largely of GCB DLBCL. It encompasses most double hit DLBCL. It's associated with inferior survival, but again, the non-molecular high-grade germinal center DLBCLs subsequently acquire a favorable prognosis. There are overlapping features of both GCB DLBCL and Burkitt lymphoma, immunophenotypically more similar to germinal center B-cell DLBCL, transcriptionally somewhere intermediate, and mutationally more similar to Burkitt. The transcriptional signatures were consistent with the rearrangements in terms of a number of downstream biological pathways that one would expect from rearrangements in MYC and BCL2, and also reflected the mutational burden in epigenetic modifier genes like KMT2D and EZH2. It was another, I think, interesting finding was that MYC rearrangements were quite rare outside of the molecular high-grade group. However, when they did occur, the breakpoints were often quite distinct from what one saw in the molecular high-grade group, and when there were single nucleotide variants, other genetic alterations besides structural variants, those also had a very distinct pattern. And so this suggested the possibility that there's even heterogeneity within MYC alterations that define distinct biology and clinical behavior amongst these large B-cell lymphomas. And then again, this was from the remodel B trial, and the addition of bortezomib had a non-significant trend to improve clinical outcomes in this group. But for reasons that we'll describe later, there may be potential reasons why this study was insufficiently sensitive for detecting a difference based on tumor biology with the addition of bortezomib. So in terms of application, I think there are a few things that we really need to keep in mind when we think about these types of multi-omic approaches. One is, of course, the test availability. Even where we practice, many of these tests are send-outs. We send them to a reference lab, and clearly for a number of novel assays, there would at least initially, this would initially require a central laboratory, certainly for standing up the assay, validating it before it gets propagated to individual centers. The turnaround time is critical for a number of reasons, but certainly in the setting of large B-cell lymphomas, there are a number. It's well established that the diagnosis to treatment interval has prognostic implications, and so imposing an additional delay in treatment initiation for high-risk patients would clearly be adverse. You have to consider the failure rate of the assay. For example, in the Remodel B trial, the gene expression assay failed 15% in 15% of cases, which is well within the range where you clearly need to have a more robust backup option. And given the timing considerations, really have to do it in parallel, at which point you have to consider it really raises the bar for the marginal value added by the molecular test beyond the existing standard, which is immunohistochemistry. And of course, there's the cost. This is very much, evolving. The costs are coming down fairly rapidly. Personally, I think it will be not too far in the future when we will be able to have kind of multiple NGS assays in the clinical setting where cost would not be the barrier. I think analytical validation could be the barrier, but cost would not necessarily be the barrier, at least where I'm practicing. So in terms of the Harvard diagnostic experience, I certainly wish that I could give you something more inspirational, but we are still using the Hans criteria to assign cell of origin as an example. All of our consults come to us from other centers with IHC. None of them are coming with gene expression based classification. I mentioned before that the Lymph2CX assay was made available at the Mayo Clinic in 2016, but the only reports that I'm aware of were internal Mayo reports, and I have not seen that, nor have my colleagues seen that with any frequency outside of that. There certainly has been a long-standing interest in establishing transcriptional diagnostics due to the clinical utility that we reviewed. And in fact, our molecular pathology department has conducted some, I would say, preliminary studies of nanostring-based gene expression assays, but the key challenge has been analytical. And just to summarize, immunohistochemistry, although it is in some sense the gold standard, it has a great deal of variability. And so if we are trying to analytically validate a new assay, it has to be against an existing gold standard. And if the gold standard is poor, on the one hand, the bar is low. On the other hand, we need to validate in a lot of unknown cases that do not have an established cell of origin. And it becomes challenging to say what the gold standard in that case would be, unless there was some other CLIA certified gene expression based test, which I mentioned before. Possibly we could use the Mayo Lymph2CX platform on the basis that it was CLIA certified and was offered at some point, but you can see that there are a number of kind of operational barriers to doing this. So really the barrier for us is not cost. It's really kind of the challenges in analytical validation. So we are still using immunohistochemistry, although we would certainly like to have more advanced options. In terms of therapy, similarly, I as a molecular biologist and someone who is eagerly anticipating the realization of precision medicine, I would say we're relatively imprecise. We remain fairly imprecise, and so I can summarize the Dana-Farber lymphoma group's practice here, which is that for DLBCL, including double expressor, we use RCHOP on the basis of a number of studies, or I would say conflicting evidence, but the preponderance of which was negative, that intensified approaches improve survival in these cases, given the increased toxicity, at least in the patients that we're treating. Now, for high-grade B-cell lymphoma, we do use intensified therapy. Generally, we use dose-adjusted R-EPOCH. For Burkitt lymphoma or Burkitt-like lymphoma in young fit patients, we tend to use modified McGrath, and in older unfit patients, we tend to use dose-adjusted R-EPOCH. We rarely use hyper-CVAD at our institution based on tolerance and the lack of, I would say, the lack of compelling data showing an improvement in survival outcomes, not counterbalanced by toxicity. And so we have this is just, in our group, we have kind of a formal approach where we implement our therapeutic we meet every 3 months to review our group's practice based on recent data. And we have this program called Pathways that we use, and as part of our kind of treatment ordering. And again, I wish that we were more advanced. We don't really have a high-grade B-cell lymphoma specific module, but for these double-hit lymphomas, we use dose-adjusted R-EPOCH as our standard for advanced stage disease, as shown. So this is largely the basis. The studies that are encompassed in this retrospective analysis are what has motivated our practice. And at this point, this is a fairly dated reference. Nonetheless, it remains kind of compelling in terms of the proportion of patients who achieved CR with R-CHOP and other intensified and a number of intensified regimens, showing, I would say, compelling data for dose-adjusted R-EPOCH in this population, and also reasonable tolerance. And then there was another meta-analysis that was a year later that showed a similar finding in that dose-adjusted R-EPOCH had a conferred superior survival to R-CHOP alone, and the intensified regimens suffered from greater toxicity, and as a result, we're still using dose-adjusted R-EPOCH. Now, I do want to say, and coming to the end of my talk, I'm very much looking to the future in molecular, in precision medicine informed by molecular approaches. And I think it will be, despite the lack of data to date, and despite the fact that our therapies are unfortunately still fairly empiric, we're working to enable precision therapy through the development of a number of molecular panels for B-cell lymphomas, as well as individual lymphoma subtypes that are compatible with both tissue as well as plasma. We are convinced that it is important to evaluate multiple classes of genetic variants, as well as both genetic and transcriptional features. And so here, what we're showing is that this was from a recent paper that was validating the molecular signatures that I reviewed earlier. And this group looked at gene expression, but also looked at mutations, and showed that in these double hit signature positive cases, there were also significant enrichment in mutations in a number of genes, including MYC and EZH2. And there was enrichment of mutations, different mutations than the double hit signature negative cases. Now, I think it's interesting to note that there's mutational alteration of MYC in addition to the rearrangements that you would see by FISH. And then there were other features as well. And so here we're looking at the MYC locus on chromosome 11, and seeing that there are not just that there are cases that are negative for MYC rearrangements by FISH, where you can pick up copy number alterations that are important, not just copy number alterations in MYC itself, but also in microRNAs and long non-coding RNAs that are influential, or either downstream of MYC, or are positive regulators of MYC, all of which converge on activation of MYC biology. And so this supports this further motivates the approach to look at gene expression, as well as to look at multiple classes of variants when we are designing and deploying our DNA sequencing panels. Again, this is another report from a couple of years ago that looked at liabilities in FISH, even in break-apart FISH, in that we are identifying a number of cryptic alterations in these genes that escape detection by even, I would say, like modern cytogenetic approaches. And then lastly, there are a number of genetic alterations that alter the expression, but biological alterations that dysregulate the expression of these key genes, including BCL2 and MYC, that are negative by FISH, but you can find through, in this case, it was whole genome sequencing. And in MYC, again, there's not just copy number alterations of MYC itself, but also of the PVT1 gene, which can activate MYC when its own promoter is deleted, and then miR17HG, which is downstream of MYC signaling. All of these can converge to a similar biological endpoint, but require different diagnostic modalities to detect. And so ultimately, I'm just returning now to the issue, that one of the biggest challenges, which is, we understand biologically that we need to detect these alterations, and we probably need more than one approach. And as an aside, there are a growing number of centers here who are using, the field is clearly moving towards some combination of whole exome sequencing and transcriptome sequencing for aggressive lymphomas. That's something that the NCI has been advocating, and MD Anderson as well is, I think, moving in that direction. But how do you do this within a clinically tractable time frame? There were a series of papers over the last 3 or 4 years that established the prognostic significance of time to treatment initiation, and this is felt to have potentially confounded some of those failed phase 3 trials in DLBCL. So many of the patients that many of the patients who need intense, potentially stand to benefit the most from biologically informed intensified therapy are some of those that can afford the least to wait for the results of the tests that will guide that therapy. And so that's a major challenge. In my discussions with Dr. Antal, I understand that there's kind of the flip side of the coin is that, in many of these data sets, the patients who waited a very long time also had worse prognoses for other reasons that were reviewed in these papers. But there is kind of a sweet spot of expeditious initiation of optimal treatment that we need to really, that we need to continue striving to fulfill. So all that being said, clearly the field is moving towards molecular guided therapy. The technology is advancing, but the challenges really are less cost at this point and more the clinical tractability and the turnaround time in what is already a very challenging clinical situation where we need to initiate treatment expeditiously for patients with high-risk disease. And that is probably the most significant in the case of these high-grade B-cell lymphomas that we reviewed. So in closing, I just wanted to thank a couple of my colleagues, including Dr. Annette Kim, who is one of my molecular pathology colleagues here at Harvard, as well as a couple of my clinical colleagues, Dr. Merriman and Dr. Kim, who have much higher volume clinical exposure and shared their clinical perspectives with me in preparation for this talk. So thank you for your time, and I'm happy to take questions at the end.
Thanks, Mark, for a wonderful presentation. Wow, that's very impressive. I just wanted to ask about FISH testing. What is the sort of success rate that you have at Harvard? Do you have any idea? Do you have many failures? And my second question is about copy numbers, the significance of that, because I tried to look up that, and there was sort of conflicting data on the.
Okay. In terms of the failure rate, our failure rate with FISH testing, unfortunately, I don't have that. I don't have that information. In terms of like technical failure rate, I don't have a quantitative answer to that, unfortunately.
Okay.
Kind of subjectively, I feel like we have pretty good success, that it's not commonly an issue. I mean, we do certainly have the situations where we get kind of limited tissue and there's like very low tumor involvement. But we're generally, I would say that we're generally able to kind of rebiopsy when we feel it's necessary to make appropriate therapeutic decisions.
Okay.
But I don't have a number for you. In terms of copy number alterations, I would say I'm biased based on our experience with molecular classification of regular DLBCL. But I would say I would say that it's quite important, and I guess I would say it's more from the biological perspective than necessarily based on clinical data. I don't have as much clinical data for that, but certainly biologically, there are numerous other examples besides those that I showed with Mick, where there's a long tail of copy number alterations, SNVs in like non-exonic regions, promoter alterations, epigenetic alterations that biologically converge on the same effect as copy number gains or losses. And so I would say almost every large-scale molecular study that we perform, where we do use a whole exome based approach, we do find in that long tail rare copy number alterations that intuitively would recapitulate, would converge on biological dysregulation of a pathway that's affected by structural variants, for example. So I would say every assay that we are currently developing in lymphoma right now, which are several, both for pan lymphoma assays as well as histology specific liquid biopsy assays, even, all of those are targeting copy number alterations as well as structural variants.
Okay.
We have to be judicious in the genetic footprint, of course, because some of these assays need to be very parsimonious, but we're always looking for them. One last thing that I would say from a technical standpoint is that it is a big challenge with the structural variants because, as you know, the ability to detect them efficiently is based on read length, and with most of the tissue we're getting being archival, that the FFPE tissue imposes significant constraints on read length and the ability to detect the sensitivity for intronic alterations. And so we have to make strategic decisions on how much real estate we're devoting in our panels to identify these structural variants. And copy number as well is a challenging topic because we're also finding that there's a great benefit in identifying allelic copy number alterations, not just total copy number alterations. And there are some challenges there. For example, in a project that Dr. Antel and I are working on, we base a lot of we leverage population-based SNP frequencies. We bait those SNPs to seed the assay for sensitive copy number detection, especially for situations like copy neutral loss of heterozygosity. And that's very dependent upon a detailed understanding of the genetic variation, the polymorphisms in the population. But that will be very different in a place like South Africa from Boston. So there's these molecular panels are like onions, and there are many different layers that have to be considered. And it seems like there's a never-ending source of technical variation and challenges.
I see, Mark. There's a question in the chat box. Malherba wants to know about clarification regarding time to chemotherapy.
Yes.
So he just wants some clarification on that. So is it that patients who have, my understanding was that if you have a delay in chemotherapy prognosis, am I correct?
Well, that's a really great question. And I'm glad that someone asked for us to go over this again, because I think it's kind of, there's like a bimodal distribution. There are patients who have high risk features, who have higher stage disease, worse performance status. Many of those end up getting treated very quickly. Patients who can afford to wait a little bit longer often do so while a more extensive diagnostic evaluation occurs. But at least in Boston and in most centers, academic centers in the United States, we see these situations where a patient just needs to start therapy now, and those patients tend to have a lot of the adverse prognosis features. So there's a little bit of skewing that you see in a number of clinical trials where a lot of the high-risk patients were excluded from the trials because they couldn't wait for the eligibility determination. And so all of these different retrospective studies used different time periods. Some of them were like 0 to 7 days, 7 to 14, beyond 14. Some of them were 0 days to 1 month, beyond 1 month. The point is that patients that get treated very early are highly enriched in adverse features. Patients that get treated very late are kind of mixed, but there's a subset of them that do very poorly, because when they go back and look at the factors for delayed treatment initiation, it would be like socioeconomic barriers or other comorbidities, or delays in diagnosis, for example. And so early and late are both enriched in patients who do worse. And so the interesting thing about the clinical trial experience, like Remodel B being just one example, but there are others, is that we frequently see that the control arm or the control arm does much better in these studies than what we typically experience in our clinical practice. And one of the several potential explanations for that is this kind of preferential the depletion of these high-risk patients because of the time involved in not only enrolling to the study, but also performing these additional tests. One thing that I would want to say, because I think it's important, is that we recognize this issue. We try to circumvent it through a number of means, and they tried to do that in Remodel B. For example, they allowed patients to initiate therapy expeditiously with just R-CHOP for cycle 1, and then the molecular testing was going on in parallel, and then patients went to an intensified regimen in cycle 2 and onward. So that's one way that you can attempt this. In Remodel B, the turnaround time for the gene expression profiling was reported to be a mean of 8 days, which that was of a total of, I think the time to treatment initiation, the average time to treatment initiation in Remodel B was like 14 days, which is pretty good actually. But I think the point is that even beyond the time for molecular testing, there are other things that go into enrolling patients on trials that you're well familiar with, that kind of deplete some high-risk patients. One other thing that I would say, just to kind of provide more of like the Harvard experience, I suppose, is to give you other examples of the turnaround time for some molecular assays here. One assay that that is available but is not commonly used, there's the Foundation 1 heme assay, is a total nucleic acid test that has a DNA sequencing component as well as an RNA component. It's not whole transcriptome sequencing by any stretch, but there is an RNA component to it. It's very expensive. It's like several $1,000s per test, but several thousand US per test. The turnaround time they claim is average of 8 days, 7 to 8 days as well. And that's very efficient for that type of a test. But you can see that there's like a minimum that it does introduce some complexity and time into the early treatment process.
Thanks very much, Mark. In the interest of time, I'm going to move on. Gives an appraisal on the management of high-grade B-cell lymphoma. I thought we'd just do a poll to get a sense of what the practices are across our country in terms of treatment of high-grade B-cell lymphoma. Vernon, shall we go ahead with Samira's presentation, and then we can present our findings later?
Sure, perfect. Thanks, Fatima. Okay.
Samira, can you go ahead, please?
Sure. Sorry, I'm struggling to share my screen. Give me a sec.
Perhaps while Samira is sharing, I can just quickly show. Okay, we'll go back to that.
Okay, guys, I'm gonna try and keep us to our time here, so I'll modify my deep dive to a little bit of shallow dive. So going through the treatment considerations, so the optimal treatment for high-grade lymphoma is still to be defined. It's a relatively recent diagnostic category, and actually extrapolating data before 2016 isn't as easy as one thinks. Since high-grade B-cell lymphoma meant something different, various terms were conflated under that definition. It's also an evolving field, as I highlighted in my first bit, and as surely as Prof. Murakami also has highlighted, the diagnosis is still evolving. The studies looking at treatment are largely retrospective, and of those, they don't exclusively deal with high-grade B-cell lymphoma. So from that, subset analyses have been done, which is obviously not the best way of looking at things. Additionally, and importantly, there is no validation in randomized controlled trials as it currently stands. Evidence does suggest that there is a poorer outcome with standard R-CHOP, and dose-intensive treatment platforms are what is recommended. One needs to individualize for the patient, tolerability considerations. These are an elder patient group, often with poor performance status and often with advanced disease. Prof. Murakami did allude to the study. So this was a 2014 multi-center retrospective study looking at 23 centers in the US and included 311 patients with double-hit lymphoma. The response rates to induction showed that a DA EPOC, which I'm just highlighting here, had a significantly better CR. And as one might assume, patients who do achieve, or rather do not achieve CR, have a poorer overall survival. In fact, it is mentioned in the same study that the 2-year overall survival for patients who did achieve a CR and were not consolidated with the transplant was 75%, which is actually far higher than the overall cohort. And that suggests that the dominant predictive factor of outcome is actually achieving CR with your induction regimen. This is also from that same study. The first figure A here shows the progression-free and overall survival at 2 years, which were 40 and 49% respectively for the entire cohort, which is, as I mentioned, was much worse than those who had achieved CR. 2B and C look at the various regimens that were used within it. Just to highlight, you can see that steep initial drop in the curves in both progression-free survival and actually overall survival for these patients. And that suggests an unacceptably high rate of early treatment failure and possibly death. These last 2 diagrams look at all patients who received any of the 3 intensive regimens pulled together compared with R-CHOP. Now, the intensive induction regimens were associated with a better progression-free survival, but there wasn't a significant difference in overall survival for the study population. Now, the study did also look at significant adverse prognostic factors, in univariate analysis and combine that in an exploratory multivariate analysis where they adjusted for these adverse prognostic factors, such as advanced age, if they had CNS involvement up front, high LDH and leukocytosis. The adjustments for this multivariate suggested that intensive inductions actually would improve your overall survival. But then there is the inherent drawback there. It is an exploratory analysis, and one can't exclude the possibility that the progression-free survival can't be extrapolated to overall survival, because then it doesn't deal with the issues of treatment-related toxicity and possibly patients who wouldn't be able to finish those planned treatments. So possibly an advantage, but not overall proven with the study. The second meta-analysis, which I think Prof had also looked at, was a meta-analysis from 2015. It looked at 11 studies with 394 patients with double-hit lymphoma. They looked at them through 3 regimens: standard R-CHOP, the majority of patients you can see actually received that, and an intermediate dosing schedule of rituximab with dose-adjusted EPOC, and more intensive regimens, so R-hyper-CVAD and the R-Codex MOL, or the McGrath protocol, which he also mentioned. There were limitations to this. So only 2 of the 11 studies, if you look at this, actually showed individual patient characteristics. So there's actually no clarity on the baseline prognostic values of these patients prior to receiving these treatments. Again, though, it does show a progression-free survival advantage with more intensive regimens, but that did not necessarily translate to an overall survival. So this was a much later retrospective. This was the epidemiological data I quoted in the earlier part of my intro. Again, older patients with poor baseline characteristics. They looked at 160 patients and again compared R-CHOP versus more intensive regimens. So again, DAR EPOC and 2 regimens I'm not as familiar with as well that were more intensive or compared as more intensive regimens with a median follow-up of 32 months. The 2-year and 4-year progression-free survival was inferior with R-CHOP, 40 and 28% compared to 57 and 52% with the intensive chemotherapy lines. Again, though, this did not show a difference in overall survival. And importantly, there was no impact for consolidating with stem cell transplant for patients that were in remission. At the top here, you can see the progression-free survival. The intensive arm is in blue with R-CHOP or R-CHOP-like regimens in red with a clear benefit seen with the intensive regimens. But when it comes to overall survival, we have flattening of these curves and actually not a statistical difference in outcomes. There were 2 prospective trials, which I'm going to discuss briefly as the very 2 recent and highly quoted trials. So the first one looked at c-Myc rearranged B-cell lymphoma. They looked at 53 patients who had a c-Myc rearranged a large cell lymphoma, and they looked at treatments with DAR EPOC. Now, just to show, I think there may be some confusions if you look at the double hit and the comparator arm. The single hit group is not single hit diffuse large B. It includes patients with high-grade B-cell lymphoma as well. Additionally, to mention the single hits in terms of their baseline characteristics did have worse performance statuses than the double hit group. Additionally, looking at the p-value, and the author has also commented that there isn't actually a statistical difference. So although it doesn't look as great with the single hit, I'm going to concentrate on that double hit arm. So the event-free survival for these patients at 48 months was 73%, and they showed IPI to be an independent adverse prognostic impact. You can see that those with the high IPI fared worse. There has been a criticism of this trial that there is inherent selection bias towards enrolling more fit patients. So a requirement to be in this trial was that they needed a centralized pathology review to be completed prior to starting therapy. And this would suggest that the survival outcomes might not represent actual real-world experience with DA EPOC. And possibly those more retrospective trials gave a better overview of what progression-free survival and overall survival more look like, because this is much higher than and out of keeping with what has been reported previously. Just to mention another prospective trial that was done, it's a phase 2 Hoven trial. They looked at adding lenalidomide to R-CHOP standardly in 82 patients. The idea there, or rather the theory, is that lenalidomide regulates MYC and its target genes, so there might be an advantage in patients with rearranged lymphoma. Additionally, there is some penetration in the CNS, so possibly lower rates of CNS relapse. 53 of the 82 cases were double hit or triple hit. They showed quite a good event-free and overall survival of 63 and 73% respectively, which is comparable to more intensive regimens. So further studies would be needed to validate these findings. What about limited stage disease? So as has been alluded to, patients are not very commonly having limited stage disease, and as such, there's limited data. There was a retrospective multi-center analysis that looked at 36 patients with double hit lymphoma and 4 patients with triple hit lymphoma. As you can see from the graphs, there's no significant difference in PFS or overall survival in these groups. So the benefit of intensive therapy becomes less clear, and some may recommend less intensive regimens in certain groups of patients, for example, using R-CHOP. according to your center and also according to the patient as an individual. High-grade B NOS, again, there's a lack of prospective and histological specific data. These are, again, often pooled with other aggressive B-cell lymphomas, so large amount of extrapolation and subset analysis. Additionally, the retrospective data is somewhat inconsistent. It is likely that R-CHOP is inferior and intensified regimens are favored. This 2018 review article gives a proposal for what high-grade or high-grade NOS specifically should be, or how they should be approached, possibly with a pre-phase chemotherapy with low doses of CBP, for example, if they have impaired organ function or decreased performance status, and aggressive supportive care. Then going on from that, localized therapy, disease, as was suggested, R-CHOP might be sufficient. And these are certain trials that looked at just using R-CHOP in this patient population and actually had pretty good outcomes. In more advanced stage diseases, of course, the more intensive regimens are what's recommended, except if you have an older frail patient, and then an attenuated or mini CHOP might be the best way to go. In terms of CNS prophylaxis, just like in diffuse large B-cell lymphoma, this is an area of controversy. Unlike Burkitt's lymphoma, where you have predominantly leptomeningeal CNS involvement, in diffuse large B-cell lymphoma and likely also high-grade B-cell lymphoma, the involvement is more parenchymal. So where the ITs clear as much disease is actually not as well established. What is established is that patients who do not get prophylaxis will have CNS progression. The MD Anderson Center showed a 13% cumulative incidence of progression if prophylaxis was not received. As one would expect, overall survival is much poorer in patients who have CNS disease at the beginning or at the outset. Those without CNS involvement, there was a clear advantage to prophylaxis. Overall survival was 45 months versus 14 months for those who did not receive prophylaxis. So attention to prophylaxis does seem to influence outcomes. Once again, this alludes back to the difficulties with diffuse large B-cell lymphomas. There can be difficulties delivering IV methotrexate, whether one should give it as an intercalated regimen or at the end of treatment. The timing has not been well established, but the intercalated can lead to delays in treatment cycle, which is obviously not ideal. Stem cell transplantation. So the role of this is unclear. The other considerations is this is an older patient population, and they've shown a high rate of disease progression prior to them actually getting a transplant. CR1 stem cell transplants aren't associated with an improved relapse-free or overall survival. But if you use a more less intense frontline treatment, so for example, R-CHOP, stem cell transplants definitely have much more of a role. So the same article, you can clearly see, so the blue and the yellow line are the patients who've received R-CHOP, whereas those top two lines in gray and I guess maroon are patients who had more intensive regimens. Clearly the blue arm, the arm that didn't receive a consolidated auto transplant, they fared worse than those who had R-CHOP with an auto, whereas there didn't seem to be a huge difference in the groups with intensive therapy. And likewise, you can see that with overall survival. Relapsed refractory high-grade B-cell lymphoma has a dismal prognosis. The optimal treatment has not yet been defined. A retrospective study that looked at 55% with relapsed high-grade B-cell lymphoma who received chemoimmunotherapy, very similar to what one gives in diffuse large B, for example, RIs, DHAP. The 1-year progression-free survival was 10% and the overall survival was 19%. So not great at all. What about the role of transplant? So it's still unknown whether refractory high-grade B should be approached differently to diffuse large B. As we know, auto transplant is a standard of care for chemosensitive relapse refractory diffuse large B. So they tried to look at this in the same context for high-grade B. So they did a retrospective review to address basically this question. The 4-year progression-free survival in double hit versus non-double hit, i.e. diffuse large B-cell lymphomas in this study was 28 versus 57%. You can see the double hit line in yellow. Basically, patients did far worse with transplants, with consolidation with transplants, compared to those who had just plain DLBCL. One of the caveats for this is these patients did receive chemoimmunotherapy as a salvage treatments rather than something like immunotherapy. And it's possible that that high-grade B-cell lymphomas who had already received a more intensive immunochemotherapy than R-CHOP in the upfront setting, that might account for why they did worse in the relapse salvage setting. So the treatment recommendations, data is largely retrospective. There's no standard of care, though intensive regimens are used and recommended by experts. Patient-related factors may limit these intensive approaches, though, so it's important to individualize. R-CHOP is associated with a poor outcome, but there are prospective data that's lacking and no randomized control trials. There's a higher risk for CNS disease. It should be evaluated at diagnosis, and prophylactic strategies are recommended. So high-grade B-cell lymphoma in HIV positive patients, there's limited data. The COMMON trial looked at, as an article in 2021, it looked at Burkitt's and high-grade B-cell lymphoma in HIV positive patients. I'm not going to go through it, but it was an experimental therapeutic program where patients were given this pre-treatment and then subsequent therapy according to their response. High-grade lymphomas was actually a really small component, and by a small component, I mean there were 4 patients. So they commented that relapse-free, that these patients were relapse-free at 43 to 89 months at follow-up, and that maybe they do better with R-CHOP than the HIV negative setting, though again, these numbers are incredibly small. This abstract also highlights the fact that patients are with HIV, also looks at patients with HIV, 10 patients with double hit and triple hit. The overall survival for double hit and triple hit at 5 years of 50 and 30% respectively. SA context, as I mentioned, our patients often come from a naive or defaulted background. As you saw, our patients have concurrent TB, poor performance stations and nutrition. So again, treatment needs to be individualized. We often give a pre-phase CVP at Heidelberg, which actually needs to be fractionated in some cases due to the poor performance status of our patients. Definitive therapy, we often use R-CHOP or modifications of that, the modified MACOP-B and hyper-CVAD. We look at interim scanning and then often upscale patients if they can withstand more intensive therapy. I'm not going to go into this. Things that target MEK overexpression and BCL2 expression, epigenetic inhibitors are being looked at. Most of the research is T-cell immunotherapy. Most seems to be with cabitagene leucil, sorry about that, but most experience seems to be with that, with good results comparative to that of relapsed refractory diffuse large B. And that's it, done.
Thanks, Samira. That was very good. But just share the findings of the poll. That's interesting. 53% R-CHOP, some hyper-CVAD.
Yeah, I guess we didn't differentiate between HIV positive and negative, which might also have some effect here. And a large proportion of our patients are HIV positive. So I think that probably,
yes,
I would imagine influenced some people's responses.
I think it's the population we deal with advanced disease that would not tolerate the more intensive.
Indeed, indeed.
So you want to take over, Vernon. I just want to say thanks again to Mark. It was wonderful. Thanks to Samira. I think the presentation went very well.
Yeah, from my side as well, to both speakers, we're very privileged to have had both of you today, and thanks for all the, it's really a deep dive, I think, into the molecular biology, specifically the diagnostic aspects, Mark, that I think we learned a lot from. Thank you. Samira, you've put a lot of effort into your preparation, very well done. I think your presentations, I think all the trainees, the presentations here are like your CVs. It's brilliant. It's really excellent and well done on grasping the nuances of these diseases so well. I think it's not that easy. and I thought it was really good. Fatima, thanks to you. Thank you very much for co-chairing today and for organizing and coordinating the session. I think it was really great. For those who haven't had a chance to fill in your registration, just be reminded in the chat box, there is a little a link that you can just click on to get your CPD points. And please take note, on special request, we've got Professor Peter Robenheimer from UCT speaking next week on a topic, and it comes highly acclaimed. Everybody said this is one of the best lectures they've listened to on being a rational diagnostician. So this will be of value to anybody in any field of medicine, so you can widely advertise this. So please be back here next week, Monday. We look forward to seeing you. I think this is really foundational to our clinical practice. So with that, thanks Fatima, thanks Amira, thank you Mark, thanks everybody for coming. We'll see you all again next week. Bye-bye.
Thanks. Yep.
Thank you.
Right.